Chunming Ding has a fabulous resume. He is the Dean at the School of Laboratory Medicine and Life Sciences at Wenzhou Medical University in China. He's trained in all over the place, in Boston, in Hong Kong, where he worked and was recruited by our next speaker, Dennis Low, and in Singapore before moving to mainland China, where a mere 15 years or less after receiving his PhD, he became the Dean of the medical university. So you're obviously doing something right. So congratulations, and we really look forward to your presentation. So please welcome Chunming Ding.
Okay, thank you, Kevin. When I was a boy, I was a die-hard soccer fan, but the Chinese team really sucks. So. And I also find more interesting things to do, so I'm no longer a soccer fan, so do whatever you like. Okay, so I also would like to thank, obviously, Larry for inviting me here and Meredith doing all these works to make the trip, at least so far, presentable. I'm going to talk, as my title says, blood-based screening to combat the rise of colorectal cancer in China. And I strike out the question mark because I was looking at the website of this university. It says, be bolder. So I crossed the question mark out. And this is my emails in case people want to ask questions. So I have a disclosure. So in addition to my academic appointment, I'm a founder of a small company in China, which is dedicated to developing these sort of tests. And also, I'm the inventor of the technologies that I'm going to describe. Okay? So this is part of Wenzhou. This is where our medical university is, and it has actually a lot of affiliated hospitals, not shown here. It has, like this city, quite a few small mountains, and has a very extensive freshwater system, these canals, and we are right next to the coast. So it's a very nice place. A small city by Chinese standard of 8 million people, but that's fine. So I'm going to talk about two things. One is really putting the colorectal cancer in the China context, because I know most of you probably are not very familiar with the Chinese medical system and as well as the situations there. And the second part is I'm going to offer one solution, which I think might be a way to solve the problem. Okay, so just very briefly, to discuss the Chinese healthcare system, hospitals, for example. So Chinese healthcare system is dominated, and I repeat, dominated by these very large, what we call category 3A tertiary hospitals. And there are about 1,000 plus hospitals. And all of these are located in major cities, okay? And they are huge, typically around 2,000, 3,000 beds. And our hospital that I'm gonna talk about has 3,300 beds. And the largest, 7,000 beds. And I was told they can have up to 10,000 beds when necessary, okay? And another very strange thing is people go to these tertiary hospitals for all kinds of indications. You have a cold, you have a headache, they go to these hospitals, okay? And there'll be a lot of problems if people do that. So I'm just gonna use one example. So our first affiliated hospital to our medical university, and we have second and third and fourth. And I think after that it's not numbered, named by numbers. So we have about 20 plus affiliated hospitals. But this is our hospital. This is the bird's eye view. And these areas are the inpatients, outpatients actually. These are the inpatients. And this side, I think this side is emergency. And these are the outpatient suites. We will meet the nurse and everything, and these are the rooms that the doctors see the patients. Of course, it's empty. It's taken probably very early in the morning. And these are the inpatient suites with nurse stations and then rooms typically host around 3 people to 4 people. And this is the clinical chemistry lab. There's a lot of automation obviously involved given the size of the hospital. So we do about 5 million outpatients each year. That's ranked about top 10 to 20, depending on what numbers you quote. And you'll see that it has very extensive IT system. And within the hospital, you see hundreds of these kiosks where you can do virtually everything. You can do appointments, you can print out medical records, you can make payments using your phone, so on. So these are very advanced. And on the back, there's an extensive IT network. So the hospital hires over 100 IT people to handle all of these. And they also analyze the data for research and as well as for clinical management. And MDT, the multidisciplinary team, actually is getting very popular in treating special cases and for discussions. Okay, so hospitals, and then for medical training, I did a bit of research and asked people around. So we train about 100,000 doctors, new doctors, every year, okay? And typically, it's a 5-year MBBS program like in UK and Australia. These are training after high school, so it's very different from US. And then there's a 3-year residence training. But 3-year residence training is really a new thing. It started in '93 in very few places. And it's mandated now, it will do nationwide residence training starting 2015. So that's to say most of the doctors that's servicing our people has not really go through the entire rigorous training as in most other countries. Okay. So these are the key problems. I think one is well-trained doctors are in serious shortage. I think it's obvious. And two is doctors are really overwhelmed by patient number. In our hospital, the first affiliate hospital, we do 100,000 endoscopies and 50,000 colonoscopies. And a very experienced doctor can do about 30 colonoscopies a day, okay? So not every one of them, but a couple of them that are very experienced. And I've extensive collaboration with quite a few hospitals. I know one of the doctors does 300 major surgeries a year, pretty much every day, okay, including the weekends sometimes. And because of this timing issues, a doctor can really spend very little time, if at all, to really talk with the patients. So there's a lot of tensions between doctors and patients, okay? So I think the key is really, first, is the tertiary hospital just do too many things. I mean, some of the very senior doctors sometimes do very trivial things because they're asked to do. And a number of years ago, the Chinese government, headed by the prime minister, actually, they are trying to instate this called hierarchical medical system, where you have tertiary hospital and lower level hospitals and so on. But it really didn't work at all. Okay, so all the patients still go to tertiary hospital for all indications. Okay, so let's switch gear a little bit. I'll come back to some of these points actually later in my talk. But let's switch to colorectal cancer, or CRC. And this is the global stats. It's ranked number 3 in new cases diagnosed. It's about 1.8 million people each year worldwide. And just a little less than 1 million deaths each year. It's ranked number 2. So it's a major cancer, no doubt about it. So that's the US number. It's ranked number 3 in both new cases diagnosed as well as in deaths. So approximately, we have in this country about 440 new cases per million people each year diagnosed, okay? And this is the number in China. It's ranked number 5 in both new cases diagnosed as well as in number of deaths each year. And if you look at the per million diagnosed number, it's 289. So it's lower than US. US is 440. Okay, so it's about 2/3. So that sounds not too bad. But if you look at the trend, oh, by the way, this is not the trade war, okay, so. Because you have trends and flags. So this is a very long, actually, time series for the US, starting from 1930. So you can see from 1930 to late 1940s, US have steady increase in the mortality for both male and female. So male mortality stays flat for about 30, 40 years before you have significant drops, starting maybe in the 80s. But women drops from that 1940s, okay? And the incidence also drops, okay? So these actually parallel quite well, starting in the 80s. But if you look at the Chinese number, just look at the top two lines. These are the incidence as well as the deaths. You see that starting 2000, so this is the last 12 years. I mean, this is not the newest data. Last 12 years, there's a very steady increase in both incidence as well as in deaths. And the increase, these numbers are not linear, so the increase is almost 50 to 100% just in the last 15 years also. So we have a talk by Ilya yesterday looking at other numbers, but I think that the increase in China is most significant, and there are many reasons to it. I think one of them probably we start to eat a lot of meat, red meat, in the last 20 years, and certainly also lifestyles and so on. Okay, so people have analyzed the reasons underlying the mortality drop in US, okay? And there's three main categories of contribution factors. One is the improvement in treatment, and the other is prevention, basically lifestyle changes. And by far, the largest contribution coming from screening programs. I think many of you probably are very familiar with. And CRC is actually ideal for screening for two reasons. One is this is a slow progressing disease. That means you have a long window to find the disease in a fairly early stage. And second is, whatever method you use, you can always follow up with colonoscopy to confirm and sometimes also to treat the disease. So it's rare, I think. In most cancers, it's difficult to implement a system like this. Maybe the other two examples are lung cancer with low dose CT and also breast cancer. Many other cancer types, it's really difficult to implement a screening program. So look at the 5-year survival rate, okay? So this is comparing China in orange and US in blue. The color has no meaning, okay? Sometimes you use color for different parties. I don't know which one is which one. Okay, so I use orange for China because we like the red color. So overall, you can see the 5-year survival rate is dramatically lower in China. It's less than half than those of China. And there's many reasons to it. If you look at colorectal cancer, it's 65% 5-year survival in US and 47% in China. But some other cancers, such as lung cancer and stomach, they have fairly comparable data. Pancreas, Chinese even have higher. That may be due to different pancreatic cancer types. Okay, so sorry, there's some Chinese. I know Larry said speak English, but this is a very busy slide, and it'll take me 2 hours to make an English version. So I have made this part. So this is the important part. So this is data actually generated provided by Dr. Cai. He's a leading surgeon in China. This is a hospital from Fudan Cancer Hospital. I graduated from Fudan, so I like to cite this data. So this is, I think, about 5-10 years survival data, which is a total case of 11,000 in one hospital, okay? And in that hospital, 5-year survival rate is 71.3%. So that's above the US number on average. And these are the patient stage. You can see that a significant, about 50% of patients are stage 3 and 4, okay? And their survival rate is much lower, especially stage 4. 5-year survival rate is less than 25%. If you look at stage 1, it's 96.4%, so it's very high. So it's really important you try to capture the patients in this category. So I also looked up absolutely which hospital is the best hospital in handling CRC. These are the Japanese hospitals. This is the Japanese National Cancer Institute or Cancer Center. And their 5-year survival rate for all stages is 88.5%. So it's very, very high. So I actually look at the data up more carefully. And one of the things I immediately noticed that the percentage of stage 1 patients was more than 30%, while in the Chinese cohort is 15%. That's double the number. Remember the survival for the first stage 1 is almost 100%. So that certainly contributes to this high number. So I think at least in China, in good hospitals, therapy level is getting very close to the world standard. But early screening also, the prevention protocols are actually not in place. So I also looked up the screening programs that has been performed in China. There are not many, very few actually, probably none nationwide screenings. So I list a few of them. It starts very early actually. It starts in 72, long time ago, led by a person that I respect a lot, Dr. Zheng Shu. She was the former president of the Zhejiang Medical College. She's, I think, late 80s, still go to the office every day, so it was fun. So they did questionnaires and as well as some other screenings, small scale in a small city called Jiashan, very close to Shanghai. Okay, so they did 2 studies, 72 and 89. And nationwide, there's only 1 study that I found. But this is looking at hereditary CRC, okay? And the most comprehensive study that I know of is the Shanghai study led by Dr. Cai. There are 2 programs, one starting 2007, the other is 2012. So these are very, very recent studies. And a number of other studies are being performed in a few other major cities. So let's look at the Shanghai data a little bit more closely. So they are targeting populations in Shanghai aged between 50 to 74. And the screening method is fairly crude, using, I think it's probably a little bit outdated, the FOBT assay, or sometimes they just do questionnaire, okay? Just using this method, they have screened close to 2 million on this data set. And I checked with Dr. Cai just before I left China. Now they did about 3 million people. Remember, in Shanghai, we have 30 million people. So 3 million is about 10% of the residents. So with this method, about 20% or 18.4% are screened positive by questionnaire or FOBT. So it's very high false positive rate, obviously. But only among these 340,000 screened positive individuals, only about 1/4 of the individuals opt for colonoscopy. Okay, that's about 93,000. And they've identified about 2,000 cancer patients and 18,000 patients with polyps. And you can see the stage 1 percentage is very high, actually, it's almost 50%. So these numbers are very difficult to remember. So I made it simpler in red. So assuming if you screen 1,000, you have 184 positives. And if only 1/3 goes for colonoscopy, you have about 50 people doing colonoscopy. And 1 of them will be cancer, and 10 of them will be people with polyps. Okay, so this is the rough number. So if all of them go for colonoscopy, we'll be having about 3 to 4 cancer patients for every 1,000 patients screened. Okay, so this is, I think, it's important to remember. The issue I think I already mentioned somehow is high false positive rate as well as low colonoscopy intake. And it's not surprising because I was doing this research, so I went for colonoscopy last year. The procedure itself, I was knocked out, so it doesn't really matter. But to drinking 2 liters of stuff and go to toilet about 20 times, it's not very comfortable. So I don't blame these people that they don't do it. Okay, so let's just do a reality check. I'm about 20 minutes into the talk. So one is qualified healthcare in China is provide I put some. I wouldn't say not every centralized hospital is capable. In some centralized large hospitals, and where doctors are overwhelmed by patient size, okay? So if we want to combat colorectal cancer or many other cancers as well, so we need a method, we need a screening method that are less dependent on doctor time. So if I tell a doctor, say, okay, I have a very good method, but you need to spend 30 minutes with the patient, it's not gonna work, okay? So this is the number from US that we can learn from, okay, where we can reduce mortality. Okay, so this is the challenge. So can we develop a screening method, a screening assay in China that fulfills, that's my personal opinion, obviously. One is accurate. It got to be reasonably accurate. So that means high sensitivity and high specificity in technical terms. And two, it's very important, it needs to be affordable. Because in China, a colonoscopy costs about $100 US, plus anesthesia and pathology is another $100 US. So we can develop a test that costs $1,000 US. I think economically it doesn't make any sense, okay? And three, it needs to be accessible. It's easy to perform and to implement. And also the compliance needs to be high, meaning that the patients is willing to do it, to participate in this. And fourth, I think it's also very important for a lot of screening as well as biomarker studies. It needs to be actionable, okay? Just telling the results to a patient or to a doctor is not sufficient. You need to tell them what to do next, okay? And action for this cancer, fortunately, is colonoscopy, so it's easy. But it's better to be quite specific. Otherwise, instead of doing 50,000 colonoscopy in our hospital each year, we need to do 500,000, which I don't think is possible. That means an experienced doctor needs to do 300 colonoscopy a day, so I don't think it's possible. Okay, so now go to the scientific part. Actually, before I start this part, I want to thank two persons who actually brought me into this field. One is Charles Cantor, who spoke yesterday. He was my PhD mentor. And the other person is Dennis Lowe, Dr. Dennis Lowe. He will speak next. So they really brought me into this field. And in my early years, I worked on the field called non-invasive prenatal testing. And the idea is really simple. Within the peripheral blood of the woman, of the pregnant woman, you'll find a small portion of the so-called cell-free DNA are derived from the fetus, okay? Typically around 5 to 10%. And if you can analyze that 5-10%, you can look at the genetics of the fetus. And there are a few successful stories, particularly for aneuploidies. I think in China, last time I checked, among the entire pregnancies, 30% did this NGS-based aneuploidy test. So it's amazing, yeah. So this is done, I think, at least for aneuploidy. Not so much for single gene disorders, but for aneuploidy, I think it's done. Okay. Move to the cancer field. Similar story, okay? Within the peripheral blood, a portion of the DNA are derived from the cancer. But the amount of DNA derived from cancer is highly variable. Unlike in the fetus, it's relatively stable. So it could be up to 50% or even 90% for very late stage cancer. But if we're talking about early stage, where we are targeting because we want to screen the patients at early stage, it could be just 0.01%. That's one out of how many? 10,000 molecules actually are derived from the tumor. And that's not a simple task. So I like to use an analogy. This is almost like running 100 meters at 13 seconds. I think most people can do it with some training, or if you are gifted, then you can probably run it right away. But if you were talking about 0.01%, that's like running 100 meters at 9.4 seconds. Okay, so I think that's really the most daunting task. Liquid biopsy has a lot of advantages, but this is really the Achilles heel where we really need to tackle this problem. Okay, so we set out to do this when I moved back to China almost 4 years ago. Actually, it's one more day, it'll be exactly 4 years. Okay, we have a few programs. I just want to talk, before I talk about CRC, I want to show you the data on lung cancer. Okay, so look at two major lung cancer types, the adenocarcinoma, as well as the squamous cell carcinoma. So these are the samples we have collected and the patients we have recruited. So one of the shocking data I can show you is for adenocarcinoma, for our cohort, 73.4% are stage 1 lung cancer, very early stage. Okay, this is really thanks to very wide adoption of low-dose CT within our region and hospital. So they really have a lot of discoveries of early stage. But it has a byproduct. The patients, the doctors tend to overtreat. So we have actually over 342 cases where they went for an operation to remove the tissue, and turns out to be benign. Okay, there's a lot of overtreatment, almost 20% of the entire cohort. Okay, but this is very good for research because we have tissue and blood for these benign as perfect controls. Okay, they show up as these nodules in the lung by low-dose CT. Okay, so this is the CRC data. And we have recruited about 1,500 patients, which are diagnosed, confirmed as cancer, and about 800 as polyps, and over 200 as healthy individuals. And if we look at the stages of our Wenzhou cohort, our local hospital, as well as the Shanghai cohort that I showed you about 10 slides back, you can see that stage 2 and 3 are fairly comparable, but we have actually more late-stage cancer. And not surprising, because I think people in Shanghai probably are more conscious of their health. Okay, but we also have more early stage. So I don't know why this is the case. But this is the cohort, fairly comparable between two cities. One is we call first-tier city, and we are considered third-tier city. Okay, I don't know what that means. But liquid biopsy can really have a lot of clinical applications. One of them already surfaced as being used quite widely now in the clinics is companion diagnostics. For example, to determine whether lung cancer patients can use these TKI drugs. But I think a much bigger market or much bigger utilities are in early detection as well as in managing patients. Okay, so go back a little bit, just on CRC screening. What we already have, FOBT I mentioned. This is testing the blood in the stool, and a slightly improved, more specific version called FIT. Similar concept, but it has slightly better performance. Actually, I took this, my friend sent this to me. Singapore is implementing a nationwide screening using FIT. I think it's free, so everyone can just give the stool in these small packs to the lab and they will test. Certainly not the case in China yet. These are newer, less invasive tests. There are two of them. One of them you're probably very familiar, Exact Science, the colon guard, and they published a paper in New England Journal of Medicine almost 4 years ago now, which they show they have very good sensitivity. It's a complicated test, including DNA methylation markers, mutation markers, as well as FIT. It's complicated to process, but nonetheless, it has good sensitivity. The specificity is not so good. I'm sure insurance company doesn't like this number that much because there's about 13.4% of false positives. And this is another test, less successful commercially. This is based on blood. Okay, looking at one single DNA methylation marker called septin9 and testing that to determine the risk of colon cancer. It has very good specificity, over 90%, but the sensitivity is fairly miserable. Overall sensitivity is about 50%. We have a similar product approved by the China FDA, but I think the clinical utility actually is not that great. I think mostly because probably sensitivity is not that good. Okay, So what do we need to do to develop a good screening test for CRC in China? So first we need to obviously have a hypothesis, okay? So our hypothesis is I mentioned this, basically based on cell-free tumor DNA in the blood. And get samples, which I've told you, and then also then develop assays, and then validate your results, and then in China we have to do a clinical trial. These are so-called category 3 medical device. It needs to be approved by the central Chinese FDA, just like drugs, okay? So you have to do this. This is very different from US where you can have LDT tests. And then you need to enter the market, and then of course you need to do post-market study and so on. So we start to identify biomarkers using our own cohort. I don't want to bore people with all these technical details, but we look at both somatic mutations as well as DNA methylation markers. I just want to point you to this part. This is comparing methylation of the same individual with cancer tissue, cancer cells, and the adenoma cells, these pre-cancer cells. There's virtually no difference at the methylation level between these two. Vast majority of the methylation changes occur when normal cells are transformed into adenoma cells. So this is good news. That means DNA methylation change is a very early event. And we can identify lots of these markers, actually. The numbers in tens of thousands. Compared with somatic mutations, we have probably tens or at most hundreds. So methylation markers, I think, is a good source. In addition to many other good properties, maybe Dennis will discuss later, but I'll skip that part. But nonetheless, I just want to tell you, we use DNA methylation markers to do the test. And there's a lot of boring things that you don't even want to go to test which marker is good, okay? So we start with 100 markers and look at each individual markers using real clinical samples. It is, I think, 50,000 of qPCR reactions. So I don't want to go through this. You'll fall asleep in a minute. But nonetheless, at the end of the day, we have about 10 markers where we are able to multiplex this into one tube, and we can do the test. So the workflow is fairly simple. We start with about 10 milliliters of blood. We do the ordinary sample processing, and then we do qPCR, and then we report. Okay, so we are able to show that compared with single markers, we can improve the sensitivity about tenfold, which is really important because we are really detecting very low amount of DNA. So any improvement in sensitivity without sacrificing specificity is great. And we were able to detect up to 0.05% of tumor DNA in the plasma. So, and it's fairly quantitative. It's not very quantitative, but it's fairly quantitative. So it's good news. And we look at a number of cases. This is a stage 1 female patients where we have complete data set of CT, colonoscopy. We also have tissue samples, we have pathology, and we have our own real-time PCR assays. Okay, I don't want to bore with you. There's another case. This is stage 2 female samples, where we have a very strong, actually, DNA methylation signals. Okay, so with that, we did an initial assessment with about 152 samples. We have a few different versions of assays as we go. We improve upon each other. So this first V1 assay achieved a sensitivity of close to 90%. This is a single tube qPCR assay. But the specificity wasn't great. It's 82.2%. And we look at the data, we do a lot of other things. Okay, oh, sorry. Okay, we did a bit more. So with our IRB, actually I advertise this with my WeChat. Within 2 days, we have more than 100 volunteers to give us blood. So this is just to assess in real life situations what our specificity is. I mean, among these 100 healthy volunteers, it's unlikely to detect any cancer patients. Remember the number I gave you? Among 1,000 volunteers of age between maybe 50 and 70, 74, you probably have 3 or 4 cancer patients, CRC patients. So 100, it's not going to give you any real positives. So nonetheless, with V1 assay, we have about 20% positive rate. So this is fairly comparable to the 80% plus specificity. So 14 of them are willing to do a colonoscopy, and 8 of them we identify adenoma. So I think it's not too bad. I think it supports what we have identified in the last cohort. So we did a lot more work and tried to improve the test. And this is a V2 assay. We know our specificity was bad, so we removed certain markers. So this one, we achieved extraordinary specificity, 98.1%. But the sensitivity is lower. It's about 70%, okay? And the cohort is slightly larger, it's close to 300 individuals. So we did a bit more work, and actually a lot more work, and now we have our V2 assay, V3 assay, which we think is gonna be the winner. So we are now doing a third-party blinded sample set of 300 individual samples, and we're gonna do this test in the next couple of months, actually. We'll see the results soon. Okay, so this is a complicated slides. Why I think blood-based tests may be an even better test than stool. And stool is already doing a very good job. And one of the reasons is stool sample is a really complicated process. Even for exact science, I think they have to process all the stool samples in their own facility. In a country like China, it's not possible to have one factory handling 50 million stool samples a year. So, but blood is easy. You can draw blood almost everywhere. And with our assay, it's based on qPCR. And virtually every hospital have a qPCR machine. So it becomes very accessible. With that, more individuals are likely to do the screening. So I think we are potentially more likely to, it's a technical term called cancer yield, which basically means how many cancer patients can you identify in a screening. So I think, I don't want to go to technical details, but I think blood may have certain advantage in China to implement. Another application we can use, because this assay is highly specific for colon cancer, and it's quantitative. So we can look at the response of the patient to certain treatments by looking at the blood levels of these markers. So this is one individual where she went for neoadjuvant therapy. And you can see just with one cycle of chemotherapy plus this antibody treatment, their ctDNA level dropped by 99%. With 2 cycles, it dropped to virtually undetectable levels. So we know at around 3-4 weeks, this patient is responding really well to the neoadjuvant therapy, and she was able to do surgery successfully, and she's still doing very well now. And you can see this is zoom in, the drop is really significant with 1 cycle. Okay, so this is my second last slide. I just want to emphasize a point on precision medicine. This is actually from Charles. So what is really precision medicine? I mean, we talk about this title so many times. And Charles says, which I agree 100%, it means better treatment for everyone, but it got to be at lower cost for the entire society. So I think, to me, so we need a baseline affordable quality care system where it handles vast majority of the patients with quality but at low cost. And then it's possible to do really, really personalized and potentially more expensive care for the rest of the population. I echo yesterday Fisherman's talk. In China, a renowned physician like him spending hours discussing one case, it's a waste of time. He could be already treating 5 patients just by himself. So I think this probably also is applicable to other society issues. Okay, so this is really my last slide. This is my group. It's a very old picture, but at least have 2 most important students who did the study, Ms. Zhu and also Ms. Ye. And these are the 2 clinicians really work very closely with us. And Dr. Xu Chang actually joined our lab meeting on Sunday morning every week. So it's a great help from her. That's my wife. She designed a lot of assays. And that's my 1-month-old boy. Otherwise, my wife will be here, but you know why, okay? So this is my last slide. Thank you very much.
We have time for just a couple of questions. If anyone has a question, please put up their hand and we'll run a mic to you. There's a question right in the back.
Is the reason that you are looking for new methylation markers because there are differences in the methylations between U.S. and Chinese colorectal cancers?
There are certainly differences. But I think the reason we look even more carefully is just this is a very difficult problem. 1 or 2 or 3 markers is not going to do it. So we have to have quite a few number of very good markers. So that's why we did it.
But doesn't the methylation pattern also tell you something about organ of origin when people are doing more general liquid biopsy, just looking for cancer types?
Yeah, certainly DNA methylation can be tissue specific, and Dennis did a lot of pioneer work on this. But not every, or most of them are not that tissue specific. So you also need to screen a lot of markers to find good ones.
One question, final question here. The lady here.
Oh, I just wanted to comment.
On the mic.
I really like the multidisciplinary group meeting, and do you think that's successful and something could go on more in the U.S.?
And this gentleman had a question. I'll be generous.
Just real quick, what kind of primers do you use that would be specific for methylation?
These are ordinary primers. We have to do a treatment we don't like called bisulfite treatment to distinguish methylated and unmethylated DNA.
I see, thank you.
Okay, we're going to close there just because we're running a little bit late on time. So let's thank Chunming Ding again.